Your doctor looked at your chart, saw your blood pressure was creeping up, and prescribed a beta blocker. You went to the pharmacy, picked up the bottle, and you have been taking this pill faithfully every single morning, maybe for 5 years, maybe for 15. You trust the system. But lately, something feels fundamentally wrong. You feel exhausted. You've gained weight inexplicably despite not changing your diet. You've slowed down, your joints feel heavy, and when you look in the mirror, you simply tell yourself a lie that millions of people tell themselves. Well, this is just what getting older feels like. But what if I told you the true culprit stealing your energy, altering your metabolism, and putting you at risk of a fatal fall isn't your age at all, but the very pill sitting inside your daily organizer right now? Right now, over 40 million Americans over the age of 60 are taking beta blockers. 40 million people. And a growing number of cardiologists and researchers are quietly asking themselves a very uncomfortable question in the break rooms of hospitals. Should all of these patients really be on these drugs? My name is Dr. Evan Carter. I am a cardiac surgeon with over 2 decades of experience operating on the human cardiovascular system. And today we are going to have the honest, unvarnished conversation that your doctor simply did not have the time to give you during a rushed 10-minute appointment. We are going to look under the hood of your own body. We are going to expose exactly what this medication is doing inside your aging blood vessels, your pancreas, and your brain. But more importantly, I am going to reveal why a landmark medical trial was completely halted ahead of schedule because of this exact class of drugs. Why did this drug fail so badly in a clinical setting? And if it failed, why is your prescription still being automatically renewed month after month? Keep watching, because the answer to that question could literally change the trajectory of the rest of your life. To understand the danger you might be facing every morning, you have to understand the history of what you are swallowing. Beta blockers have been around for over 60 years. The very first one, propranolol, was developed back in 1964, and at the time, let us be fair, it was genuinely revolutionary. Scientists discovered that by blocking certain specific receptors on the surface of the heart muscle, they could artificially slow the heart rate, reduce its daily workload, and reduce the force of each individual beat, bringing blood pressure down significantly. Doctors were genuinely excited, and they had every reason to be. Through the 1970s and 1980s, beta blockers became the absolute go-to drug for high blood pressure across the entire Western world. If a patient walked into a clinic with hypertension, a beta blocker was almost automatically the very first thing written on the prescription pad. It felt safe. It felt proven. It was what every major medical school was teaching year after year to thousands of young doctors. Here is the simple biological version of how these drugs work inside your chest. Your heart has receptors that act exactly like little electrical switches. When you are stressed, when you are frightened, or when you are physically active, like walking up a steep hill, your body releases adrenaline. That chemical flips those switches and speeds your heart up rapidly to deal with the demand. Beta blockers act like a chemical wall. They block those switches. Your heart beats slower, it pumps with less force, and your pressure drops. Sounds perfectly logical, right? But medicine has learned a massive amount since 1964, and the science has moved in some very surprising directions. And tragically, some of what medicine learned didn't automatically make it back into every local doctor's office. That is the gap we need to talk about right now. When you are 60, 65, or 70 years old, your cardiovascular system operates very differently than it did at 40. Your resting heart rate is naturally lower. Your blood vessels are less flexible and elastic. They have stiffened with decades of use. Your kidneys process and clear medications much more slowly. What works perfectly in a 45-year-old body can behave very differently, and sometimes profoundly harmfully, in a 68-year-old body. Because your heart rate is being artificially capped and slowed by this drug, it physically pumps less blood per minute. Let's think about basic plumbing and oxygen delivery. Less blood moving through your system means less oxygen is being delivered to your working muscles. So when you try to climb the stairs, walk to the mailbox, carry groceries from the car, or play with your grandchildren on the floor, your body simply cannot respond the way it used to. Your heart is physically prevented from speeding up the way your muscles are desperately demanding. It is exactly like trying to drive a car up a steep hill with the engine electronically capped at half its normal power output. You push the accelerator to the floor, but nothing happens. But this fatigue isn't just making you tired and robbing you of your daily joy. It is hiding a terrifying metabolic trap, a trap that increases your risk of developing a chronic, incurable disease by nearly a quarter. What exact disease is this blood pressure pill pushing you towards while you sleep? I will explain exactly how it alters your internal organs in just a moment. Before we uncover that hidden metabolic trap, I have a very important question for you, and your answer matters more than you might realize. I want you to tell me honestly in the comments below. If you are over 60 and taking metoprolol, atenolol, or bisoprolol for your blood pressure, think back carefully to when you first started. Did your energy levels drop? Did you slow down, abandon your evening walks, and just quietly accept it as a natural part of aging? Leave your answer in the comments right now because I read them, and your experience might validate what thousands of other people in this community are feeling completely alone in their homes. Now let's talk about the side effect that rarely, if ever, makes it into routine 10-minute office visits. Beta blockers, particularly the older generation of these drugs like atenolol, are measurably and scientifically associated with a significantly increased risk of developing type 2 diabetes. How high is this risk? Studies show an approximate 22% increase in risk compared to patients taking alternative blood pressure medications. I want you to sit with that number for a second. That is not a trivial statistical blip. 22%. That is nearly 1 in 4 additional patients developing a serious, lifelong chronic disease that they might never have gotten otherwise. A disease that aggressively damages your kidneys, destroys your vision, causes peripheral neuropathy in your feet, and actively attacks your cardiovascular system. All from a drug they swallowed specifically to protect their cardiovascular system. The biochemical mechanism behind this is actually quite well understood by researchers. Beta blockers interfere directly with how your pancreas functions. They alter how the pancreas releases insulin in response to the blood sugar from your meals. Furthermore, they reduce insulin sensitivity in your muscle tissue, meaning the sugar stays in your bloodstream longer. Simultaneously, they tend to artificially raise your triglyceride levels while actively lowering your HDL, that is, your protective good cholesterol. The cumulative result of all these chemical changes is a metabolic profile that is pushing your aging body in exactly the wrong direction, year after year. And remember that mysterious weight gain I mentioned earlier? The weight that just won't come off no matter how many salads you eat? The drug modestly slows your resting metabolic rate. Combined with the crushing fatigue that forces you to sit more and move less, the pounds accumulate quietly and steadily over months and years. Patients blame themselves entirely. They think they are eating too much or lacking willpower, when in reality, the medication is doing the heavy lifting on the bathroom scale. So, this pill drains your physical energy, raises your blood sugar, and packs on weight. But the most immediate, life-threatening danger doesn't happen when you are awake and moving around. It happens in the dead of night, in the dark, when you simply stand up from your bed to use the bathroom. Why are these pills causing fatal accidents in the dark for seniors? We are going to break down that terrifying mechanical failure right now. Let's talk about falls. Specifically, the direct, undeniable connection between beta blocker use and fall risk in older adults, and why this particular risk is so massively underappreciated in standard medical practice. Here is exactly what happens physiologically in your bedroom at 2 a.m. You have been lying down sleeping or sitting quietly for a few hours watching television. You stand up quickly. Normally, in a healthy, unmedicated cardiovascular system, your body compensates almost instantly and automatically. Your heart rate ticks up for a second, your blood vessels tighten slightly, and your blood pressure stays perfectly stable as you rise against gravity. But on a beta blocker, that rapid, life-saving compensatory adjustment is severely blunted. Your heart physically cannot respond fast enough to the sudden change in position because the drug is blocking the adrenaline signal. Because the heart doesn't speed up, your blood pressure drops sharply for a few critical seconds. In those few seconds, your brain is deprived of optimal blood flow. You feel dizzy, lightheaded, or suddenly unsteady on your feet. Your vision might go gray at the edges. This experience has a clinical name: orthostatic hypotension. And in adults over 65, it is one of the single most common triggers of serious, life-altering falls. And I need to be brutal with you here because your life is on the line. A hip fracture in someone over 65 is absolutely not a minor inconvenience. It is critically important to understand the stakes. Studies consistently show that up to 30% of older adults who suffer a hip fracture will die within 12 months of the injury. Not from the bone breaking itself, but from the terrifying cascade of events that follows. The complications, the prolonged immobility, the hospital-acquired pneumonia, the deep vein blood clots that travel to the lungs. It is a deadly chain reaction that starts with one single wrong step in the dark. And here is the part that genuinely concerns me the most as a physician. Most patients experiencing orthostatic hypotension don't even recognize it as a medical problem. They just feel a little dizzy sometimes when they stand up. They grab the bathroom counter, they sit back down on the edge of the bed for a minute, the feeling passes, and they go back to sleep. They never mention it to their physician because it seems minor, it passes quickly, and it doesn't feel like a symptom worth reporting. If that description sounds familiar to you, or to someone you care about, please write it down specifically and bring it to your next appointment. That moment of dizziness when you stand up is not something to dismiss as just getting older. It is a major clinical finding. It deserves a clinical response, and it may be directly, not indirectly, but directly, connected to the medication in your pill organizer. With all these documented devastating risks, crushing fatigue, a 22% higher risk of type 2 diabetes, and deadly nighttime falls, you must be wondering, why on earth did your doctor prescribe this to you in the first place? And why haven't they taken you off it? The answer involves a massive 2005 medical study that literally shocked the cardiology world and rewrote the rulebooks in Europe. But before I reveal the shocking truth about the ASCOT trial and tell you exactly what modern alternative medications you should be asking your doctor for instead, make sure you hit that subscribe button right now. Every single week, I bring you the honest, unvarnished, evidence-based medical truth that the traditional, overworked healthcare system simply does not have the time to explain to you. I decipher the medical jargon so you can protect yourself. Subscribe to this channel so you can take control of your cardiovascular health before you ever need to meet a surgeon like me on an operating table. Now, let's go back in time to 2005. A landmark study was published called the ASCOT trial, the Anglo-Scandinavian Cardiac Outcomes Trial. This study changed everything we thought we knew about blood pressure management. It compared beta blockers directly, head-to-head, with a newer class of blood pressure drugs called calcium channel blockers in a massive group of patients with hypertension. The results of this trial were so clear and so profoundly striking that the trial was actually stopped before it was scheduled to finish. Early termination. Why? Because the patients taking the newer calcium channel blockers had significantly fewer strokes, fewer heart attacks, and a notably lower risk of developing diabetes. The beta blocker group didn't just perform slightly worse, they lost by such a wide and undeniable margin that continuing the comparison was considered ethically wrong to the patients involved. After the ASCOT trial was published, major medical organizations around the world started quietly updating their clinical guidelines. Some moved faster than others. The British hypertension guidelines actually moved beta blockers off the first-line list for uncomplicated high blood pressure. That is a massive shift in medical policy. Other European guidelines followed suit, and the American guidelines became significantly more cautious about their routine use in simple hypertension. But here is the systemic failure, the critical gap that genuinely concerns me as a practicing physician who sees the aftermath. Medical guidelines change in thick medical journals and textbooks. They do not automatically change what is already written on your prescription pad at your local pharmacy. That renewal just gets processed by a computer. Millions of patients who were started on these drugs 5, 10, or 15 years ago are still taking them today, completely unaware that the science has moved on. Their doctors are overwhelmed, the clinic is packed, and the prescription simply auto-renews in the system. Nobody stops the conveyor belt to ask, is this actually still the right drug for this specific person today? So, knowing all of this damning evidence, knowing about the fatigue, the diabetes risk, the falls, and the ASCOT trial, should you just walk into your bathroom and throw your beta blockers in the trash today? Stop right there. Absolutely do not do that. For 3 very specific groups of people, throwing this pill away could trigger a fatal cardiac event within days. Are you in one of those 3 danger groups? Let's find out right now. I need to be brutally clear and entirely transparent with you about something important, because I do not want anyone watching this video to walk away with a dangerous misunderstanding. Beta blockers are not evil drugs. In the right patient for the right underlying condition, they are absolutely unequivocally life-saving medications. I prescribe them regularly in my own surgical practice. There are specific clinical situations where stopping a beta blocker would be genuinely, immediately dangerous. Number 1, coronary artery disease or a prior heart attack. If you have diagnosed narrowed arteries supplying your heart, or if you have already survived a heart attack, beta blockers are a genuine cornerstone of your ongoing protection. They protect the vulnerable heart muscle by reducing how hard it has to work each day, and they measurably reduce the risk of you suffering a second fatal cardiac event. In this specific context, they are not optional. Removing them would be irresponsible and highly dangerous. Number 2, heart failure. If your heart has reduced ejection fraction, meaning it isn't pumping blood efficiently with each beat, certain specific beta blockers actually improve your survival rates. Drugs like carvedilol, metoprolol succinate, and bisoprolol are essential to heart failure management. Number 3, arrhythmias. If you have an irregular heartbeat like atrial fibrillation, beta blockers help regulate and control your heart rate day to day. They reduce the risk of dangerous rhythm disturbances and keep the heart beating in a controlled, manageable pattern. Furthermore, and this applies to everyone, you must never stop taking a beta blocker abruptly on your own. Not tomorrow morning, not after finishing this video, not ever. Why? Because your body has physically adapted to the constant presence of this medication over many months or years. That adaptation is real biology. Your heart, your blood vessels, and your entire nervous system have recalibrated around this drug. If you suddenly remove the chemical wall blocking your receptors, there is a documented violent rebound effect. Your adrenaline receptors, having been blocked for so long, suddenly become intensely hypersensitive. Your heart rate can spike dangerously. Your blood pressure can surge to extreme levels incredibly rapidly. And this sudden rebound can precipitate a serious cardiac event, like a heart attack or stroke within hours or days. The correct and safe way to come off a beta blocker is gradually, with the dose reduced incrementally in measured steps over several weeks, under strict and careful medical supervision. So the question is never as simple as, are beta blockers good or bad? The right question is, what exactly is this specific drug doing for you, right now? If you only have uncomplicated high blood pressure, if you don't have heart disease, if you don't have heart failure, and you don't have an arrhythmia, what are the modern alternatives? What can successfully lower your blood pressure without stealing your physical energy, threatening your pancreas, or causing you to fall in the middle of the night? If beta blockers are no longer the recommended first choice for straightforward, uncomplicated high blood pressure in someone over 60, then what is? Current medical evidence points very strongly toward two major, highly effective drug classes. The first is calcium channel blockers, with drugs like amlodipine being the most common and well-known example. These drugs work by directly relaxing the muscular walls of your blood vessels, making them wider, which makes it physically easier for blood to flow through them. Critically, they do not block adrenaline. They do not interfere with your heart's natural ability to speed up during exercise, meaning they don't cause that crushing fatigue. And they do not raise your blood sugar levels. The ASCOT trial I mentioned earlier specifically proved that they reduce stroke and heart attack risk far more effectively than beta blockers for simple hypertension. The second major alternative class is ACE inhibitors and ARBs. Common examples include medications like lisinopril, losartan, ramipril, and candesartan. These medications work entirely differently. They block a specific hormone system in your body called the renin-angiotensin system, which is one of the primary drivers of elevated blood pressure. These drugs also carry incredibly meaningful protective effects specifically for your aging kidneys. And crucially, they carry a much cleaner metabolic profile. They don't promote insulin resistance, they don't raise your triglycerides, and they don't cause you to gain mysterious weight. You now have the science. You understand the physiology of your own body better than millions of people currently swallowing pills blindly. The only thing left is the execution. How do you take this information and actually use it? How do you bring this up with your busy doctor without sounding like a difficult, arrogant patient who has been consulting Dr. Google? I want to tell you what I think about sometimes on my drive home after a long, exhausting day in the operating room. I think about those 40 million Americans over 60 taking beta blockers. I wonder how many of them are sitting in their living rooms right now, utterly exhausted, believing with absolute certainty that their fatigue is simply their age. How many have quietly stopped taking evening walks or stopped playing on the floor with their grandchildren because the stairs became too difficult? How many have grabbed the bathroom countertop in the dark, steadied themselves as the room spun, and then gone back to sleep without ever mentioning it to anyone? The invisible erosion happening quietly in people who are doing everything right, taking their medication faithfully, and still slowly losing ground. That is what keeps me motivated to speak to you today. Here is the single most powerful, practical thing you can do today to reclaim your energy and protect your future. Take a piece of paper right now and write down this exact sentence to hand to your physician at your next appointment. Doctor, I have been on a beta blocker for blood pressure for X years. Given my current conditions and today's evidence-based guidelines, is this still the best medication for me? That one specific, polite, informed question could be the single most important health action you take this entire decade. Medicine is not static. The best physicians update their thinking as medical evidence evolves, and the very best patients actively, bravely help them do it. Being a well-informed patient who asks questions is not being difficult. It is being your own best advocate. You have lived a long life. You have earned the right to understand exactly what chemicals are entering your bloodstream. And you have earned the right to a medication that allows you to actually enjoy your retirement with energy and vitality. Remember, everything I have shared today is general educational information. Always consult your personal physician before changing, stopping, or starting any medication. Take care of your heart. It has been working for you, beating faithfully every single minute of your life without ever asking for a break. Give it the exact tools and the exact information it needs to keep beating strong. I'm Dr. Evan Carter. I'll see you in the next video.